Hello, everyone, and welcome to Caring and Living as Neighbors Parallel event, brought to you by Clan Mates for Kids and Lehigh University. My name is Nikki Pasterchik, a youth representative to the United Nations for Clan and an undergraduate molecular biology student at Lehigh University. I will be co-hosting this event with Kate Armstrong, president and co-founder of Clan, and Katie Blankvist, Mates for Kids project officer and public health master's student, also at Lehigh University. Please ensure you are muted if dialing in virtually. Lastly, this event will also be recorded and posted soon with a report afterwards on Clan and Mates for Kids websites. We would like to acknowledge the lands that everyone is dialing in from virtually. We invite you to post the traditional lands you're on in the chat now. From Lehigh University in Bethlehem, Pennsylvania of the United States, I acknowledge I am presenting from the lands of the Lenape people, and I pay respect to elders past, present, and emerging. As Clan is based in Australia, we acknowledge the traditional owners of country throughout Australia and recognize their continuing connection to land, waters, and community. We pay respect to First Nations peoples internationally and to their cultures and elders past, present, and future. This event is hosted in partnership with the Lehigh University United Nations Youth Representative Program. The Lehigh Youth Representative Program started in 2008, where high-achieving Lehigh University students are matched with UN-accredited NGOs. Clan is one of 9 NGOs and one of Lehigh's strongest partners. This program allows youth to have a voice in global matters, and in our case, advocacy and action for children who are living with non-communicable diseases. This year's Commission for Social Development focus is fostering social development and social justice through social policies to accelerate progress on the implementation of the 2030 Agenda for Sustainable Development and to achieve the overarching goal of poverty eradication. This is Clan's first side event at the Commission for Social Development. Our session is titled Newborn Screening, Promoting Equitable Healthcare for Every Child, regardless of economic status. Newborn screening is a well-established technology that has an important role to play in redressing child health inequities globally. When universally available, newborn screening promotes early and equitable access to diagnostic and therapeutic options for children living with non-communicable diseases that could otherwise cause enormous preventable morbidity and mortality. Newborn screening programs contribute to efforts to achieve the Sustainable Development Goals by 2030 by contributing to health and well-being, reduced inequalities, and leveraging partnerships. For those unfamiliar with the specifics of newborn screening, it is a heel prick method where blood samples are taken from a newborn and tested for multiple genetic, metabolic, endocrine, and other long-term conditions. This is pivotal for children with chronic conditions that are important to diagnose and treat within a few days of birth in order to prevent morbidity and mortality. From a personal perspective, my older brother has the genetic disorder phenylketonuria, or PKU, which was diagnosed within several days of his birth here in the United States. With newborn screening as an indicator, my parents were able to immediately integrate the lifestyle necessary for him to thrive and survive with his condition. I would now like to introduce Dr. Kate Armstrong, co-founder and president of Clan, to speak on behalf of Mates for Kids.
Thank you very much, Nikki, and good morning and hello to everybody who's joined here today. If you could change to the next slide, please, Nikki. Today is a real celebration. We have people joining from all over the world, and sincere thanks to everyone. I guess I'll be keeping my presentation brief to give everyone else plenty of time, but just excited about the opportunity really to focus on champions at this event today. The Commission for Social Development is celebrating the 30th International Year of the Family. And as Nikki's just mentioned, for her family and for so many others, particularly in high-income countries around the world, newborn screening and other initiatives to help children living with childhood NCDs make a huge difference, particularly for those living in the most vulnerable circumstances or for children with conditions that, if not diagnosed, can have really devastating effects. Unlike Nikki, I have had personal experience of a child born with a condition where today newborn screening in Australia would have diagnosed it, but as a family we went through a very difficult time because we didn't have newborn screening. So I personally am very passionate about the importance of newborn screening for every child, but also for every family. Thank you, Nikki. Next one. I'd like to continue on from Nikki's warm acknowledgement of country and acknowledge that Clan is headquartered on the lands of the Wallumattagal people of the Eora Nation here in Sydney. I'd also like to acknowledge the many experts and elders in the field of newborn screening from around the world, and also the wonderful partners that we have, because no one can do this alone. And I'd particularly like to acknowledge Lehigh University for the wonderful partnership that Clan enjoys, and the many Mates for Kids partners that we work with around the world. Thanks, Nikki. So a brief overview of what I'm going to be talking about, just briefly introducing Mates for Kids, talking about the 30 by 30 by 30. It's the 30th year of the family, but our bold goals as well, and then highlighting a few champions. But I thought that this statement was really important. The Commission on Social Development says, to leave no one behind, we need to adopt comprehensive, inclusive social policies, bridge digital divides, shift our mindset and prioritise advancing social progress and wellbeing for everyone. And we really did feel that a focus on newborn screening and other initiatives to help save the lives of children living with NCDs was a very appropriate focus for this event today in our efforts to leave no child behind. Thanks, Nikki. So the Mates for Kids movement is a really exciting network coalition of amazing people from around the world. And we have been very bold in our goal to reduce the preventable mortality associated with one particular childhood NCD by 30% by 2030. This aligns with broader efforts to achieve the SDGs, notably 3.2.1, 3.2.2 and 3.4, but many others beside, as Nikki has pointed out earlier. We started with some meetings with WHO in late 2021 after hearing about the situation for children in Zimbabwe who are living with CAH, and presented a briefing paper to WHO in February 2022, and all of this information is available on the Mates for Kids website as well, and you can read more. But we have chosen to be bold with a 30 by 30. Next, thanks, Nikki. Building on that 30 by 30, acknowledging the 30th year of the family, it's a great time to be focusing on newborn screening. Why newborn screening? How does that fit? More Mates for Kids, we decided at our strategic planning meeting in Buenos Aires last year that we would focus on 3 strategic objectives to achieve our goal: improving access to essential medicines and equipment, strengthening CAH communities, and scaling newborn screening. Thanks, Nikki. Just want to touch on connecting champions and the way that Mates for Kids works. We bring together champions from each of the 6 WHO regions: the Americas, Africa, Europe, the Eastern Mediterranean region, Southeast Asian region, and the Western Pacific region. And we come together for quarterly community of practice meetings where we use the knowledge to action framework to identify challenges, identify local solutions, implement action, share our results and our findings, and really continue to learn on that. We leverage events. We're very grateful to WHO for hosting our community of practice on their knowledge action portal. We're really committed to using data, evidence, indicators to track our progress. And we are committed to a person, family, community-centered community development approach to everything that we do. And that's informed by the 5 pillars of CLAN, the Australian NGO. Thanks, Nikki. Speaking of celebrating champions, this is a wonderful time to announce some grants that the Mates for Kids Network promoted to support newborn screening and community development initiatives for the benefit of the CAH community around the world. And we're very proud to announce the winners of our 2024 community development grants and newborn screening grants. This year, all of the applicants that were successful, and we'd like to acknowledge Dr. Paola Duran from Colombia and Drs. Navoda and Sumadu from Sri Lanka. They are focusing on community development activities. We will be hearing from Dr. Navoda later in our session today, but I'd just like to briefly acknowledge we do have Dr. Paola on the line. Paola, did you briefly want to, congratulations, did you briefly want to share what you'll be putting your funds towards?
Yes, thank you very much for this opportunity. Really, in Colombia, there is not an established community of patients living with congenital adrenal hyperplasia, and there's no clear statistical data about this condition. So we are going to do with CLAN the first club meeting for people living with CAH in Colombia, which aims to identify and understand the challenges and barriers faced by this community. And also we will identify recommendations for realistic multi-sectorial actions that can be implemented to optimize the patients' and families' quality of life. So this will be our first club meeting, and we are very happy and very grateful to have this opportunity. Thank you very much.
Thank you so much, Dr. Paola. That's so exciting. And I'd just like to acknowledge the International Society of Neonatal Screening and Lab Systems for the wonderful Gerard Lober Award that they gave to myself, and acknowledging the work that CLAN's been doing over many years. And the funds from that award are what is funding these wonderful activities. So congratulations to everybody who's received those grants. Next, thanks, Nikki, sorry. We'd encourage everyone to just continue engaging with the Mates for Kids movement and sharing your successes. We love to hear about it on the WHO's CAP. We're going to continue posting good news stories and promoting them beyond Mates for Kids. We encourage you to share your good news story with us. Please reach out to myself or Katie, our wonderful Mates for Kids project officer. We will have a UN Women event coming up in March, CSW 68, and we encourage you to join for that. We'll also be applying for an event at the Small Island Developing States 4 conference in the Caribbean later this year, in May this year as well. So we encourage you to get involved. And thank you, Nikki. That's really all from me, and I will pass back to you, Nikki. Thank you.
No problem. Thank you so much, Kate. I would now like to introduce Elizabeth Page, followed by Dr. Aman Palungan, to speak on behalf of Indonesia.
Hello everyone. My name is Elizabeth Page. I am an Australian scholar with the New Colombo Plan, which is an Australian government initiative to send young Australians to study and work in the Indo-Pacific region. I'm currently undertaking an internship with CLAN in Indonesia, based in Jakarta. Here I've had the privilege of working with Professor Aman Palungan and the wonderful team at Global Child Health Foundation, YKAG. Over the course of my internship, I've been particularly focusing on newborn screening, an area that Indonesia has been making great strides in, particularly over the last year, with 1.2 million babies screened by the end of 2023. A few weeks ago, I had the enormous privilege of interviewing the Indonesian Minister of Health, Pak Budi Gunadi Sadikin. I was able to achieve this amazing opportunity to speak with such an important figure in Indonesia, thanks to Professor Aman, Plan Child Health, and the New Colombo Plan Scholarship. The purpose of the interview was to discuss with the Minister the incredible progress that Indonesia has been making in newborn screening and to be able to share insights with other member states so that they might learn from the experiences and successes of Indonesia. So today, I would love to share with you some of the key takeaways and things I found most interesting from my talk with Pak Budi. There will then be a short clip from my interview for you to watch, and if you'd like to watch the full interview, a link will be provided in the chat. So if I could have the first slide, Nikki.
Would you like the video at the end or beforehand?
At the end, please. Thank you. So I began the interview by asking the Minister why newborn screening is a priority for Indonesia. And we discussed how newborn screening was a critical component for reducing child mortality. The Minister informed me that Indonesia is aiming to decrease the current infant mortality rate in Indonesia from 19 deaths per 1,000 live births to below 10, and that newborn screening is a big part of that vision. He also spoke about how newborn screening was not only important for identifying conditions that contributed to child mortality directly, but also that impact morbidity in terms of physical and intellectual impairment. Next slide, please. Next we spent some time discussing the current newborn screening situation in Indonesia. He told me that there are 4.8 million babies born each year, but that only 2.3% were being screened for congenital hypothyroidism at the start of 2022, after the program had been around for just over 20 years. He said that in response to these low rates, he relaunched the newborn screening program in 2023, and by the end of the year had reached a coverage of 65%, a huge increase in just 1 year. The Minister was then excited to announce that the target for 2024 is to reach 90% coverage by the end of the year. He also said that due to the current success of the program screening for congenital hypothyroidism, this year Indonesia will begin a pilot project to add congenital adrenal hyperplasia and G6PD deficiency to the newborn screening program. Next slide, please. I then asked about what level of staffing and resourcing has been required to scale the program to this level and to continue to progress it further. He said that the program had been extended from just 2 labs at the start back in 2000 to 11 hospital clinical labs at present. But he said that this was still insufficient for providing newborn screening across such a big country. So having received funding this year from World Bank, the Minister informed me that Indonesia intends to use this grant to develop a more encompassing public health infrastructure and increase to 34 public health labs. Next slide, please. So following on from this, I was interested to know more about how newborn screening was being made available across the Indonesian archipelago with its 7,000 inhabited islands and 280 million people. The Minister responded by sharing with me about Indonesia's long-standing public health network, particularly its district-level community health centres known as puskesmas. Pak Budi explained how these puskesmas have been successfully utilised to carry out newborn screening, because it is here that the majority of Indonesian babies are being delivered. He then spoke about the success of introducing a mandate in 2023 in September that newborn screening must be provided in order for Indonesian healthcare workers to claim delivery rates from the National Health Insurance. This is just one example of how the Minister's background in finance has enabled him to bring a helpful perspective to the role of Health Minister about the connections between economics and health in Indonesia. Next slide, please. Thank you. The Minister spoke at length about how newborn screening is a key aspect of Indonesia's pursuit to become a high-income country. He said that having a smart and healthy population can improve income generation and so increase GDP. In this way, by enabling the early diagnosis and treatment of congenital conditions, newborn screening can contribute in a significant way to boosting GDP and helping Indonesia become a high-income country. It was interesting to me the way that the Minister conveyed this message with a degree of urgency. He told me history has shown that every country has a specific window of opportunity to become a high-income country, which is when they're at their peak demographic bonus, and that for Indonesia, this window is only 6 years away in 2030. The Minister spoke passionately about the importance of prioritising and progressing newborn screening so that Indonesia does not miss this window and they can hope to become a high-income country in the future. Finally, if I could have the next slide. Here in Indonesia, in just a week's time, we will be having a presidential election. So the last part of the interview I'd like to share with you is the Minister's vision for newborn screening going forward and the legacy he hopes to leave. As I already mentioned, the Minister is aiming to reach 90% coverage and to include 3 tests for newborn screening before the end of the year: CH, CAH, and G6PD. He also spoke about wanting to establish a newborn screening ecosystem with a sufficient number of labs to cover the whole country, a sustainable financing structure, better healthcare worker training, and improved newborn screening education for parents. Lastly, the Minister acknowledged that despite Indonesia's increase in numbers for newborn screening, this is not the whole picture, and there is still much improvement needed to increase the quality of newborn screening in Indonesia. He particularly mentioned that there is still high parental rejection of newborn screening and of confirmation tests and treatment, and that the positivity rates for the newborn screening tests are lower than they should be. All in all, Pak Budi provided a really clear picture of what newborn screening looks like in Indonesia, and really authentically spoke about his achievements and challenges in progressing newborn screening over his time as Minister. He shared with me why he believes that newborn screening is so important and why he is so passionate about seeing all babies in Indonesia screened. It was a huge privilege to be able to have this conversation with Indonesia's Minister of Health, and I am very excited to have had this opportunity to share some of this conversation with you all today. Now I would like to show you a small video from our interview. Thank you.
Can everyone hear that video? Nikki, we can't hear the video, I don't think.
Oh, we can hear.
Test, which is the congenital adrenal hyperplasia, and
Are you able to hear now?
Could you restart it, please, Nikki?
Okay.
child mortality is very high in Indonesia. I think we are top 10 in the world. One of the things that we haven't done compared with other countries is newborn screening, to my personal surprise. Some of the newborn screening can avoid mental or intellectual or physical disorder, but some of them are also very important to avoid fatality. Starting this year, all newborn babies we screen, starting with congenital hypothyroid. But this year, because the system are already working, we can add additional 2 newborn screening tests, which is the congenital adrenal hyperplasia and G6PD. We have done is around 2% or less. So I put a very high target. Now they reach 1.2 million, already about 65% of the coverage. My target to my team, I want to increase it to 90% coverage this year. It's roughly between 80 to 85,000 every week. When we started this initiative, we didn't have the infrastructure yet. So we chose 11 hospitals to be the central public health lab to serve the whole nations. But the intention is, starting this year, we will develop the network of public health labs started from 10,000 Puskesmas, and then 514 public health labs in cities, and then 34 regional public health labs in provinces. So I believe, because we want to increase from 60,000 to 85,000 every week, and also we want to add 2 additional tests, which is the CAH and G6PD, we would like to increase the number of national public health labs that can provide the services. That was the biggest challenge. 280 million spread over 7,000 inhabited islands is a huge task. So what I did is just revitalizing and utilizing 10,000 puskesmas, we call it the primary healthcare clinics owned by the government. And one of their job is to do this newborn screening. Because the 4.8 million babies that are delivered every year, most of them are delivered at these puskesmas. So that is exactly the right place for us to do newborn screening. So they deliver the service, they will get reimbursed by our National Health Insurance Agency. Very important to have healthy and smart kids to support Indonesia and bring us to a high income country status. Now, how to make this healthy? Then newborn screening is a very critical, component how to make our people healthy. Changing the attitude and culture is the biggest hurdle. But that is the role of people like me. Instead of see only from the difficult angle, you see from the opportunistic angle and just push everybody, because we have potentials. And my short-term target, I want to cover 90% before I leave. And then second target, I want to leave a legacy, at least 3 screenings. And my third objectives, I want to establish an ecosystem, an infrastructure, establish the public health labs, the financing structure so it becomes sustainable, and also training all the doctors to understand the importance of this, educating the mothers. And number 4 objective is to make sure that the treatment, the follow-up treatment and the quality of treatment is there. Because when I see, yes, we have a very large number of screening, but the reject rate is high and the positivity rate is below standard. So something is still not right. I want to spread this news to all mothers in the country so they understand when you are pregnant and you're delivering your baby. If you want your baby to be healthy and smart, you have to do newborn screening, and it's given free by the government. So just ask.
Thank you so much, Elizabeth. I would now like to introduce Aman to speak.
Thank you, Nikki. Also, thank you, Kate, and thank you, everybody. I think it's a great honor for us here from Indonesia that, we can share what's the progress. And I think we have to learn a lot also from all of you here, because what we're sharing here probably, a lot of other things that we can improve. Can I have a slide, please? It's okay. Yes, this is what I would like to share, what we are doing already and what we are going to achieve for the future. Next slide, please. Thank you. So, every year we have 4.8 new babies are born. So this is the size of Singapore population. This is all the 17,000 island and 7,000 inhabited. Next slide, please. The last data that I got it, from 2022, of course, after the pandemic, you can see here, there is so little data about Indonesia in this publication compared to, let's say, Japan, Philippines, even Sri Lanka, and Taiwan, and Vietnam. We are far below them. Next slide, please. So, like Kate mentioned before at the beginning, that's the target for 2030. So the 30 things. That's the most important thing is point number 3. Next slide, please. Yes, we have to ensure that healthy life and promote well-being for all ages all ages, including newborns. Next slide, please. And this global target for goal number 3 is non-communicable and environmental disease. It also calls for more research and development, increase health financing, like our Minister of Health said, and strengthening capacity of all countries in health risk reduction and management. Next slide, please. So the early identification of inborn disorder newborn screening program is crucial in safeguarding children's well-being, mitigating potential long-term health impact. Most developed countries have introduced national newborn screening programs more than 20 years ago. So to provide early asymptomatic recognition, define a panel disorder where early treatment is effective. Newborn screening is also becoming available in many developing countries right now. So we are going to achieve that. Next slide, please. Next slide, please. So what's the challenge in developing country like Indonesia? Of course, lack of resource, quality, patient care, but it should be political will. So this is what we get right now from our government, especially our Minister of Health. So should be political will. If you want to start it, there should be political will for this. Next slide, please. So we start with congenital hyperthyroidism, CH, and this is the history. Well, start from more than 20 years ago. So there is a pilot project, and then start with 1999. We get little support from the atomic energy, and then we start 2006 with the profession, gynecology, obstetric, and also Indonesian Pediatric Society. And then 2008, still nothing happening. And we get the legal aspect, the Minister of Health decree in 2014, but no budget, and after that, nothing going on. But in 2022, there is a relaunch of newborn screening. And by 2023, there is a new decree from Minister of Health. And you can see that what's the achieving right now. Next slide, please. Massive increase we read right now. Next slide, please. And by 2022, you can see at 2019, only 2.5% baby. And the data from our data from our publication. Next slide, please. From 4.8 million babies, our data is quite, surprising. Next slide, please. So for CH, we have 1 in 2,500, but for CAH, that's about 3 out of 3,000. So it's we are really afraid that our CAH patient also a lot compared to other countries. That's why this year we have to start with the CAH beside the congenital hyperthyroidism. Next slide, please. So this is what we target right now. Until December 2023, we have reached almost 3 million baby screen. So about, of course, 28% of the babies born. So you can see here what's the increasing, and we have data also from the all province. Next slide, please. But the massive increasing by 2023, the end, December, we have reached 65% of the baby screen. So 60,000 baby screen. Yeah. So you can compare to other countries who reach 100%. How many baby they screen for 1 year? We screen for 1 week, 60,000. And this year, we are expecting 80,000 baby every single week. So we are expecting about 90% of baby screens. Next slide, please. So the plans for 2024, we are increasing our targets, coverage of the baby screen, 90%, and to add screening for CAH, G6PD, congenital heart disease, and also hearing problem. Next slide, please. Lesson learned. So we have to prioritize newborn screening, and it gives an opportunity for every baby to live and grow healthy. Commitment and harmonious collaboration between stakeholders, overcoming technical barriers, increasing number of labs, of course, especially in Indonesia with 70,000 islands. Training health worker. Indonesia is vast geographic location. We are the biggest archipelago in the world. Integrating newborn screening and healthcare system and program, increasing awareness, of course, for mother's family to consent for screening. Next slide, please. Let's strive to ensure all newborns are screened. Thank you again. I think it's our honor today to share in United Nations and 62nd Commission for Social Development. Thank you. Over to you, Nikki.
Thank you so much, Elizabeth and Aman, for your contributions, as well as for the video on behalf of the Minister of Health. I would now like to introduce Raul Calzada to speak on behalf of Mexico.
So, good day again. I hope you can hear me clearly. Next slide, please. So I'm going to talk about the neonatal screening in Mexico, the evolution of this. The next, please. It all began in 1973 to 1977 when Dr. Antonio Velasquez carried out the first study analyzing phenylketonuria, galactosemia, maple syrup urine disease, homocystinuria, and tyrosinase. This project, although it was exitous, it was canceled in 1977, although it demonstrated its feasibility and effectivity. However, Dr. Velasquez did not give in to adversity, and with the support of the National University of Mexico, he established a laboratory named Genetic of Nutrition Laboratory in collaboration with the National Institute of Pediatrics in 1986. I was in my first years of pediatric endocrinology fellowship in that time. And we began to collaborate with him in the endocrinology service from that time. Next, please. We collaborate with the National University of Mexico, with the Faculty of Medicine. Then after with the Metropolitan University in Mexico, with the very good results about the mental disorder in that kind of child. And last with the Mexican Society of Pediatric Endocrinology, which I was the founder, and we sums of efforts on behalf of this program. Next, please. It all began with Dr. Antonio Velasquez, here is he, and Dr. Marcela Vela, which was working in the first year of the specialty with Dr. Velasquez. And in the endocrinology service, this is mine, science time ago, and Dr. Carlos Robles, which was in that time the chief of the endocrinology service. Next time, please. Next. In this time, I mean that the detection of congenital hyperthyroidism and phenylketonuria was the main objectives. In the first study, in the initial sample, more than 140,000 children were included, and the concentration of TCH was determined using a spectral immunoenzymatic assay with a cutoff value of 30 microunits per milliliter. Then we learned that was very high. We found 78 cases of congenital hyperthyroidism, which allowed to demonstrate a general incidence of one child in each 1,97,000 newborns, and in the population treated in private institution, more frequent in the open population, and in the beneficiary of the Ministry of Health. It was a very, very high incidences in Mexico. Now our incidence is 1 in 1,200 patients. Next slide, please. We got that in September of 88, was generated in Mexican official standard number 34 and published in the official Gazette of the Federation, which made neonatal screening mandatory throughout the country with a cutoff value of 15 micrograms per milliliters in umbilical cord or 10 micrograms in HIL. In 1992, we created 3 more laboratories in the north, the middle, and the south of the country, which began to operate or cooperate to cover the entire country. In 1994, one laboratory was in each state of the country, 32 laboratories then in the country, just working for neonatal screening. In 1997, the Mexican Consensus Group of Pediatric Endocrinology, currently the Mexican Society of Pediatric Endocrinology, demonstrated to the health authorities several failures of the pre-analytical, analytical, and post-analytic phases, and proposes viable solutions which allow for substantial improvement in the effectiveness of the procedure. The cutoff value was then marked as 10 in HIL or in umbilical cord. Next slide, please. Multiple national recognitions. Even we won the Queen Sophia Award in research in 2001. And this is a photo which it was delivered to Dr. Velasquez in behalf of the Interior Group. Next slide, please. We create a multidisciplinary working groups with the inborn errors of metabolism laboratory, genetics, imagenology, psychomotor stimulation, gastroenterology, cardiology, statistics, endocrinology, and nuclear medicine. And this is the names of the one that has been participated in this time in each service. And we got to cover more than 99% of the Mexican population. And the age of which treatment began has been lowered to 10 to 15 days of life for all the diseases. Next slide, please. However, in 2018, there was a lot of equivocal and illogical decisions. For example, neonatal screening cannot be performed if the patient has more than 5 days of life. And in our population, in the little towns and in the mountains, the people goes to a medical service after 1 or 2 weeks of life of the patient. So now they cannot be receive the benefits of this. It's a delayed sample processing process, lack of coordination between findings and abnormal results and giving the information about it to the family. It's a very, very much less efficiency and effectiveness. There is no information on procedures, guidelines, verification of results, mechanism to reporting result of age at which the treatment begins. Next slide. So at the present, we are analyzing only these diseases: cystic fibrosis, congenital hypothyroidism, congenital adrenal hyperplasia, galactosemia, glucose 6-phosphate dehydrogenase, and phenylcetonurate. 6 years ago, we have 24 diseases analyzed. Now, we are covering less than 45% of the population. And the results and the parents are informed more than 72 days of life of the patients. Congenital hypothyroidism, for example, we got the confirmation diagnostic at 7.8 days of life, and now we are confirming it at 87 days of life. Congenital adrenal hyperplasia, we got to confirm the diagnosis at 8.2 days of life, and now the diagnosis is more than 90 days of life. In 48%, the diagnosis now is made due to an adrenal crisis and not by the results of the neonatal screening. Next slide. So for many years, the national program was coordinated and supervised by the National Institute of Pediatrics, later by a national center, which was continued to actively collaborate. But in recent years, the budget decreased by 60 to 70% because it was delivered to popular support program to students and elderly people who receive $100 per month. But with this, they ensure votes for a political party in the power. Now we are restarting the path again to combine politicians of the benefit of carrying neonatal screening, ensuring with a coverage of 100%, coverage all newborns, as well as ensuring the procedure to make it efficiency and effective. So it has been a large weight, and we are now to fight again with a political decision that was not benefits for our population. Thank you very much.
Thank you so much, Raul, for your great input. I would now like to introduce Navoda to speak on behalf of Sri Lanka.
Thank you, Nikki, and for inviting us to discuss this important humanitarian aid that we received from MAIDS Australia. Can I get the first slide, please? Yeah, ADRG Hospital is one of the largest hospital in Southeast Asia. The main reference center for subspecialties. Next slide, please. It has a population of 22 million. It's home to many cultures, languages, and ethnicities. It's a tropical island in South Asia with high biodiversity, rich in natural beauty. And we have two official languages, English being the linked language. The two official languages are Tamil and Sinhalese. So according to World Bank ranking, we come under lower middle income country. And we are located in Southeast Asian region. Next slide, please. Few statistics of our country. Under 5 mortality rate per 1,000 live births. In 2021, the total was 6.74, whereas male under 5 mortality was 7.39, and in females it was 6.03. In 2022, it was the total under 5 mortality rate was 7. So over the years, the under 5 mortality rate was coming down, Next slide, please. Neonatal mortality rate per 1,000 live births also demonstrated the same improvement from 4.52 in 2017 to 3.85 in 2021. These are the latest figures we have at the moment. Next, please. However, the government expenditure on health during 2017 to 2023 went up because of the depreciation of the rupee as well as the economic crisis. Next slide, please. So this is what happened to us. Big inflation and the crisis, the dollar value went up drastically, and the purchasing power of medicines came down, and there were many social and economic issues within the country during this period. Next slide, please. And in Colombo, Literature Hospital is situated in Colombo, so many patients are coming from faraway places, Jaffna, Polonnaruwa, Batticaloa. They are more than 100 kilometers away. And during this period, even the traveling was very difficult because of the crisis. And ethnic minority is in these faraway places. Next slide, please. So this is the time we received the humanitarian aid, and we received medicine in April 2023. And it was a requirement for us to find out how to select the most vulnerable patients. So tool developed by Kate Armstrong as part of a research on nephrotic syndrome in Vietnam was used. And there were 10 indicators which reflect key social and cultural determinants of health associated with child health inequities. Our aim was to use the check scorecard to inform distribution of CH humanitarian aid to Sri Lanka and ensure children most in need were prioritized to receive essential medicines and other support required. So there were 10 indicators. Out of that, if a child scores more than 3, it is considered as the health and life-wide serious risk. So this is how we used the check scoring system. Can I see the next slide, please? So we had 270 children live with CH at that time, estimated number. And Clan made a donation of a year's supply of hydrocortisone and fluorocortisone for 10% of that population. So we, over the time, we registered 177 patients in my unit and commenced the check tool in Sri Lanka. And scores were given as proposed by Kate for each of the 10 indicators to identify children most in need. Next one, please. So majority of our children had high check scores. More than 89 scored more than 5 out of 10. 51% of children scored 6 out of 10. 9 out of 10 was the highest score. That was 57% of children. 13.2% of children scored higher than 8. And this pie chart shows the distribution of the scoring system. Let me see the next slide, please. So when you consider gender distribution as expected, there were more females than males. 45% of females and 55% of female, 55% of females and 45% of males. In Sri Lanka, the gender of patient is not generally considered to play a major role when families make decisions about seeking and providing medical care. So there's no discrimination. Both females and males receive equal opportunities for health care. Next slide, please. The distance of home from quality health care in Sri Lanka, families are usually issued 1 month supply of medicines from the government hospitals. However, all children identified through the check system who are living more than 3 hours or 100 kilometers away from the clinic were issued 3 months supply of medicine so that their traveling was reduced, because this is a time where they found it very difficult to visit the hospitals or clinics to receive their medicine. So giving more than 3 months of medical supply actually improved their compliance. Next slide, please. So the majority of the patients, the percentage of children from ethnic minority was 40% and was higher than the overall population, and 60% was ethnic minority. Why this is seen among CAH patient could be because the intermarriages are common among ethnic minorities. In Sri Lankan setting, we took specific efforts in place to support children and families from ethnic minority groups because they spoke a different language from what we use. As I mentioned earlier, there are two main languages, Sinhalese and Tamil. Even though we had a linked language, most of them were unable to communicate with English. Because of that, we made sure that we have medical professionals who speak the other language, and we made sure we have enough trainees who can speak the other minority language. So the patients were not at a disadvantage just because they were from an ethnic minority or they were unable to communicate with us. Next slide, please. The parental health literacy. At the time of donation, there were no educational materials on CAH in local languages for families. So all families were marked a point for this when we use the check system. Even though we have written information with regard to acute management of the condition, we didn't have information regarding the disease per se. Next slide, please. Child well-being. All children at our clinic are attending school, so we mark this based on the comorbidities only. So there they received 1 score when they had another comorbidity. Next slide, please. So family support networks, there are no support groups for CAH in Sri Lanka, but for diabetes, we have a parent support group, but not for CAH. So all our patients got 1 point for this. Next slide, please. So we have another unit, as I told you earlier, professorial unit. They have entered 31 patients for this community, and less than 3, the percentage of patients was 9.7, and there were 90.3% of patients who got 3 or more. 29% received 5 or more, and 6.4% of patients got 8 points out of 10, 8 or more. Next slide, please. So the medicines were distributed to children with the highest check scores, and it's we are proud to say that there were no deaths during this economic crisis due to CAH. There was no patients who got lost to follow-up, as they were given adequate amount of medicines for a 3 months period. Then they had to come only 2 to 3 times, 4 times per year. Because of that, the clinic visits improved, compliance improved, and also we noticed improved health outcome as evidenced by biochemical improvement of their disease control. Next slide, please. So what are our next steps? And our conclusion, the check scorecard was a useful tool for identifying children with greatest need. Indicator to gender will help track progress towards equity in the absence of newborn screening in Sri Lanka. Our aim is to 1.1. We don't have screening facilities. However, the pediatricians are very good at detecting ambiguous genitalia in females. And also they keep in mind that whenever a boy present with failure to thrive, to look for congenital adrenal hyperplasia. During this period, we noticed very few boys presented with adrenal crisis. And I would like to recommend 2 new indicators for this check score. One would be, does family have access to emergency injection of hydrocortisone within 1 hour of home? And the other indicator would be whether the family have an emergency number they can call for service and support during times of acute illness. This one, actually, we have provided with a phone number for them to communicate with us whenever they have an emergency. Information leaflets on acute management and crisis are now given to patients in their preferred language. This has been there already, but we would like to have more detailed information regarding CAH in 2 local languages, and it is being developed. And we need to empower patients and parents to establish functioning support group. I think this is a great requirement to improve health outcomes of our patients with CAH. Thank you very much for your time.
Thank you so much, Navoda, for your great work. Before we do our closing remarks with Dr. Kate Armstrong, I'd like to invite Diane Webster if you'd like to speak on behalf of the International Society of Neonatal Screening.
Thank you so much, Kate and Nikki, and my abject apologies for not having slides prepared for you. What Kate has asked I could talk to you about is the Global Task Force on Newborn Screening, which is a joint task force between the International Federation of Clinical Chemistry and the International Society for Neonatal Screening. It has been chaired by Professor Jim Bonham, who's the ISNS president, and Dr. Van Pineda from Atlanta for IFCC. He has recently resigned, and the co-chair will now be Dr. Aisha Habib Khan from Karachi in Pakistan. The task force has been in action for 3 years and has recently been renewed for 3 more. It has a limited budget controlled by IFCC, and they seriously limit what we can spend the money on. But they quite like us to organise in-country meetings to bring together people who have a commitment to newborn screening and talk about ways that the screening can be facilitated in the country. And we've had one in South Africa. The outcomes of that have recently been sent for publication, and one has been held in the Dominican Republic, and we have one planned for Kazakhstan in April. One of the things that I think that the group does really well is encourage people who are interested in newborn screening, and you can see from the fact that it's International Federation of Clinical Chemistry that it tends to have a lot of laboratory people involved and wanting to do screening. But an important role for us is encouraging those people to get everybody else that is needed to get good screening outcomes in the room altogether. And so by that I mean the laboratory, the maternity services who will provide the infrastructure for collecting specimens and probably also for doing follow-up, the paediatricians who will be doing the diagnosis and treatment of the screened disorders, the public health physicians, both locally and nationally, who will be involved in program monitoring, and very importantly, whoever funds healthcare in the jurisdiction, be that government or insurance or other, so that any pilot projects that get started will have an exit strategy moving towards more permanent funding. So the government in South Africa is now funding two pilots, one in Cape Town and one more rural, to look at feasibility. They thought it was really important to link biochemical newborn screening to other kinds of screening in the neonate, because they felt that even basic health checks weren't being done appropriately. And so newborn blood spots are going to be part of a much bigger project to make sure that well child, particularly newborn well child, screening and checks are done appropriately. So it's a bit of watch the space. It's a bit of, if you think that the task force could help or support what you're doing locally, do please get in touch with us. Has anybody got questions? Is there anything in the chat?
Thank you so much, Diane. We're always so grateful for your expertise and generosity, and it's so great to have you here. And terrific to hear about the task force and the work that's happening. We've had a strong interest in applying for an event leading up to the Small Island Developing States event in the Caribbean in May of this year. Can you point us to where we as advocates and civil society and people really passionate about this, where's the best place for us to get data on which countries are doing newborn screenings, which aren't? We've done surveys as the Mates for Kids Collaborative to ask countries, you know, who's doing it and who's not. Where's the best place for us to go, though, for official data?
There isn't really anywhere. It is basically the answer. However, Brad Thurl and Carmen Padilla have just finished and submitted for publication an update on their world status of newborn screening. That's going to be it's 90 pages of manuscript they've submitted. So you can see that it's really, truly detailed, full of references. The other initiative that's happening in that space is the International Society of Neonatal Screening is developing a map, and it will be interactive and it will have as much detail as we can get locally. So to do that, the structure of the map is there. It's been updated with whatever information is available publicly. It needs some work around granularity, by which I mean it doesn't make a lot of sense to talk about what newborn screening is there in India or Pakistan. It makes more sense to talk about the provinces or even smaller divisions, because it's so diverse what happens in big countries. So we might go maybe state by state by North America. That working that out is being done, and working on through the ISNS elected regional representatives, building some contacts in countries around the world. Many countries we don't have any contacts at all. Some we do, and that information is on the website. And Kate, I can send you a link. I believe it's publicly accessible. I don't believe it's members only, but I can send you a link to the map.
That's wonderful.
Hi, Kate. Diane, can I have one comment?
Yep. Very happy to hear what's happening in Indonesia.
Diane and Kate, I think, well, for the next coming assembly, is it possible that, you know, like a Kate question, I think this is a really good question. I know that, you know, Carmen and Terrell, you know, are going to publish it, you know, because they're asking also data from Indonesia. But during the assembly, is it possible that, you know, we could have one like side meeting, because all the country will be in the assembly next coming May in Geneva. Probably we can raise this issue, you know. We are achieving 30-30, but I think during the assembly, I think this topic should be one of the topic for the side event, I think, in the assembly. This is just my thought. Okay. Thank you.
I agree with you, Aman, and very happy to talk with you about that after this. And we will certainly work with Lehigh University and our UN youth reps to explore what we can do to support that. Do you have any comments about Aman's comment, Diane?
I'm not clear as to whether this would be about progressing screening for a single place or a more global meeting about progressing screening for more interested people. But I think either way, it would be well worth approaching the task force and see if they could support with some funding.
Fantastic. Noted, and we will do. Thank you, Diane. One quick last...
I'll also email you. I think you'll have Jim's email, but I'll email you that, and also Aisha's.
Fantastic. That would be wonderful. And it's great to hear that WHO is working on this now. So we will be very pleased to follow up on that, Diane. Just one last comment. What we saw from Indonesia today was just the power when the Ministry of Health and the government's fully committed to newborn screening. Is that the view of the task force also?
Not necessarily, but it would be very difficult to get task force commitment to a meeting without government funding representation being there. So it's more so that they know what is going on, and so that they can talk about what's needed from them, what their health priorities are, how, like, for example, for South Africa, they said blood spots are good, but we'd like to work it in with the physical exam.
Right. Lovely.
So well, very not absolutely necessary to have commitment to funding, but absolutely necessary to have interest and commitment ongoing.
Lovely. Noted. Thank you, Diane. We will be preparing a report on this, so we'll also follow up with you afterwards to make sure that we have the right messaging, because I think you've given us a lot of cause for hope there. So thank you to the task force for the work that they're doing. I'm mindful we have 2 minutes to go, so I will take a moment to wrap up. I'd just like to start by thanking everybody. We had the most incredible speakers sharing really fantastic updates today, and just very deeply grateful. We have a video there from the Minister of Health for Indonesia, the full video. The link is in the chat. Nikki, I might just ask you to repost that so it's front and center for everyone. I was transfixed by that video. It's excellent. The minister has such a clear vision. He's such a clear communicator. It was an excellent video, and I'd really encourage you all to please watch it and also share it amongst your networks. If you're trying to get your ministry involved, I think it's a fantastic example of what's working well. The numbers of babies being screened in Indonesia is gobsmacking. 65,000 newborns a week. It's absolutely incredible. And when you translate that to the number of babies who won't have developmental delay, who won't die because of this, it's a true contribution to achieving the SDGs by 2030. So congratulations. We heard some wonderful things from Mexico about their multidisciplinary team approach. What Professor Raul didn't get a chance to share was his amazing advocacy efforts around access to medicines in Mexico, and they're seeing some really great steps forwards there. And what we're learning more and more as we approach newborn screening is the importance of a community-centered and focused and community development approach to newborn screening. You can't implement newborn screening in isolation. Everything that community of children need once they're diagnosed with that condition has to be in place. So hats off to everything that's being achieved in Mexico. And our thoughts are with the many countries around the world where there is no newborn screening yet. And thank you to people like the team in Sri Lanka working so hard to save the lives of as many children as they can until such time as newborn screenings are in place. Thank you so much to Diane and our links with the International Society of Neonatal Screening. Thank you for your involvement in the work of Mates for Kids and your support of it. And we just are so excited to see what Colombia and Sri Lanka are going to do with their grants, and they'll be presenting to us throughout the year. Please join us at our next event at CSW 68. We'll have some more amazing champions coming to talk about different things to do with keeping children alive and achieving our bold goal of reducing the preventable mortality associated with CAH by 30% by 2030. So with that, Nikki, Katie, our young people, you're amazing. Thank you for your hard work. Thank you to all of our wonderful Mates for Kids around the world. And I think that's just about it. 1 minute late. Apologies for keeping you and stealing that minute, but have a wonderful day, night, morning. And thank you. We'll be getting a report out on this meeting within the month. I don't want to put the young people under too much pressure. We'll get it to you as soon as we can. Please save the date, March 13th, 6:30 p.m. New York time is our next UN event together. And thank you, Lehigh. Thank you, Mates for Kids. Thank you, everyone. And congratulations to everyone on the incredible work you're doing to save the lives of children. Let's leave no child behind. Thank you, everyone.
Kate and all. Bye.
Yeah, okay. Bye-bye.
Thank you, everyone. Bye.
Thank you.